So I would start the debate on biopsy post-focal therapy versus non-biopsy. And the first one is Dr. Lopez. Okay, it's the video. Good.
Good afternoon. I'm Dr. Bernardino Minana from the Clinical University of Navarra in Spain. First of all, I would like to thank the organizing committee for inviting me to participate in this meeting, especially Dr. Rafael Sanchez Salas, who is a very good friend of mine. Second, I apologize for having to leave because my flight is departing soon, and so we've decided to record my presentation. I'm in the hotel room doing this. Well, my topic is to defend biopsy after focal therapy. These are my disclosures. Today, follow-up after focal therapy is based on PSA testing, MP-MRI, and biopsies, which is the only method that can confirm any recurrence. Theoretically, it should not be skipped for proper monitoring of the disease, but there is no consensus on when and how to perform it. To address this question, we should ask ourselves, what if we do not perform a biopsy? And then we may find out different arguments. As a quality control when implementing a focal therapy program, to avoid undertreatment in patients at a special risk, to monitor medium and long-term results, and for focal therapy to be accepted as an ablated treatment. So first, as a quality control when implementing a focal therapy program, it is mandatory to assess our performance with any ablative technology. We need a quality control of what we are doing, so we have to be able to answer two basic questions. 1. Are we actually ablating the tumor? When we start a focal therapy program, which corresponds to a phase 2A of the ideal framework, we have to assess our infield tumor recurrences rate, which means the absence of any tumor in the treated volume, not any significant tumor, any tumor. And we have to reach a standard that has to be, in my opinion, previously written in the study protocol. For example, you can set more than 75% tumor-free at a specific time. Second, we have to demonstrate that we are ruling out properly patients with significant tumors outside of the index lesion volume. This has to do with the biopsy protocol and with systematic biopsies taken in the control biopsy that usually is done around 12 months, 1 year after the procedure. Let me show you an example. This is an MRI where you can see a suspicious lesion on the anterior horn of the right peripheral zone. We have taken targeted at least 3 cores and systematic biopsy sampling mainly the PC zone. Here you can see what is like an MRI 1 month after an IRE treatment, both in the axial and sagittal planes, to check that we have treated the planned volume with enough security margin of at least 10 millimeters. And this is what it's like 1 year after treatment before proceeding to the control biopsy. You can see that the PC zone has shrinked and almost disappeared, leaving a kind of scar. So, then we have to take biopsies from the scar, which corresponds to where the tumor was located before the treatment and around the treated volume, in order to assess the infield recurrences, and finally take biopsies, systematic biopsies, to assess the out-of-field recurrences even with normal MRI. Second, to avoid undertreatment in those patients at a special risk, those with tumors ISUP grade 3, those with a strong family history, especially those we know with high grade or have had an aggressive disease course, and carriers of germline mutations, BRCA1, 2, ATM, etc. That we know they are associated with higher risk of nodal involvement and development of distant metastases. Although we are not systematically testing for it because of its low incidence in this set of patients, some are coming to our clinics already diagnosed. Third, to monitor medium and long-term results in standard patients. Here the problem is when to perform the biopsy. Of course, this can be per case for any rising PSA levels of detecting new suspicious lesions on multiparametric MRI. But in the typical patients, in my opinion, it always should be decided on an individual basis depending on factors such the results of previous biopsy, PSA density after treatment, the access to different biomarkers that can change our decisions, and even on PSMA PET scans results, which of course should increase the negative predictive value, and its role is yet to be defined. And finally, this is a personal opinion, for focal therapy to be accepted as a valid treatment for all urologists. We claim, as a focal therapy society, that focal therapy is an appropriate treatment for selected patients with prostate cancer, and it is. But we need to add long-term information on what is happening in the tissue left untreated. We need to know its natural history in order to be compared with already existing information coming from whole gland treatments. So, in conclusion, irrespective of PSA values and MRI information, we should recommend a biopsy to assess the quality of our performance when implementing a focal therapy program, to avoid undertreatment in some patients at high risk, to monitor medium and long-term results, and to increase information on the natural history of treated patients in order to compare focal therapy with those treated with whole gland therapies. Thank you very much for your attention. It's been a pleasure to meet you all, and I hope there is someone in the floor that can support my arguments. Thank you very much again.
Okay, I wonder how he did that. He was right on time, so not a second too long.